Well, dear colleagues, dear interpreter, I would like to thank you for doing such an excellent job, and I hope that I do not use confusing phrases during my talk for the translation. I would like the organizers for inviting me to this beautiful venue here, and I really underestimated the degree of beauty that is meeting me here in your country, and I'm very happy to be here. So my task is to talk about hyperuricemia as well as cardiovascular and renal disease, and over the following half hour we will try to address those 4 points, starting with a different view on gout. Well, if we think about gout, we have kind of a one-track mind, but we should realize that gout is just the tip of the iceberg. And as we have learned from the Titanic, the tip of the iceberg is something you see at the very last moment, sometimes even after your boat crashes into the iceberg. So I think we have to realize that gout is just the stuff we see if we talk about gout, but the hyperuricemia is something that is going on for years and years, and there's some reason to talk about hyperuricemia. The prevalence of hyperuricemia is different from country to country. We have about a quarter of the male population suffering from hyperuricemia, and about 15% in women are also hyperuricemic. Well, now we have here one of many formats of the talks I have here. Well, this is a question I asked the man in this room. If there's a beautiful and talented woman, you know, where do you look? You know, you should look in the eyes, of course, and you should listen into the soul and the of that person. But sometimes we look also for other things. You know, not only we look into the eye of very beautiful people, and in I think in gout, we have the same problem. We focus on things that are interesting, but there is much more about gout we have to learn and we have to see. And let me take you over to the United States. If we look there, and they have very nice data on large patient populations, and what you can appreciate here is that I have not have enough learning curve with the presentation. Let's see, go back here to, so what you can appreciate here is that indeed there is a relationship between the level of uric acid on one hand and the risk of cardiovascular disease on the other hand. So this is important because it tells you on a large population scale that it's obviously not a good thing to have very high uric acid levels, because that is then associated with with cardiovascular risk. So let's switch back again. Wrong button. Out of the presentation mode, but I'm not out of slides, so the talk is not over yet. Well, once we get going again, we will I will show to you that hyperuricemia is not only related to the cardiovascular risk, but also to other things we see in the population. For a long period of time, we thought that hyperuricemia and gout is just a punishment for a bad lifestyle. Too much alcohol, too much meat, all the things we shouldn't have in our lives to eat. Interestingly, there are people around that do have a high uric acid level and do have gout without doing those dietary violations. And the question is why that is the case. So in a slide that would come up next, let's see, no, it's not moving at all. Okay, so, well, I just have to illustrate that to you with my hands. So what you would see in the next slide is, maybe I make room for the specialist to take care of that. So if you look at large patient populations, and this is something a brilliant scientist had made, she looked at the genetic material of 140,000 Europeans and was running gene arrays. And what she came up with was very interesting. She could see that indeed, if you look at, and here we go, thank you very much. Now it's working again. So if you look at genes, you can realize that there are genes responsible for gout and hyperuricemia. So it's not only lifestyle, but it's also the genetic inheritance you bear in yourself. And this is a study in which cardiologists have looked at patients with those gout genes in a large prospective trial. So over 3,000 men underwent cardiac catheterization, and they gave away biomaterials, and then they were followed for 10 years. And what the researchers could see is that after 10 years, those people with a high uric acid level had a very much increased risk for cardiovascular death and sudden death. So obviously there is a crosstalk. It's not only a statistical relationship between uric acid on one hand and cardiovascular disease on the other hand, but there seems to be a more intimate relationship. And of course, we contribute to that as well. You know that we are able to even cause a gout attack in some people by starting diuretics, combining loop diuretics and thiazides, by giving a low-dose aspirin. Those are all things that increase the uric acid level. And as we will discuss hypertension one more time in the afternoon, I would like to point out that the mineralocorticoid receptor antagonists like spironolactone, they are neutral in terms of uric acid levels. So this is one drug you can administer without getting an increase in the uric acid level. So the combination of many underlying conditions leading to high uric acid levels is best epitomized in this study in patients with acute heart failure. If you go to the emergency room with decompensated heart failure and they take your uric acid level, you have a very poor prognosis if your uric acid level is very high. As you can appreciate in this Kaplan-Meier survival curve, the red line depicts the patients with the highest uric acid level. So this is a mixture of genetic predisposition, of very intense treatment of heart failure with diuretics and everything that belongs to that, and underlying renal disease, because also renal disease is a cause of hyperuricemia and gout. So let's move on to the chronic kidney disease. After all, I'm a nephrologist, and nephrologists were very happy a couple of years ago because we were winning a kind of morbid competition. We made it into the top 10 of the leading causes of death. So of course, if you look at this list, the most important disease is ischemic heart disease. But if you go to number 9, you can read there chronic kidney disease. And chronic kidney disease is even more important and more frequent a cause of death than colon cancer. And this is important because many people are concerned about colon cancer, and rightly so, but only few people are interested in their renal function. If you look at large industrialized countries like the United States, you can appreciate that about 15% of the adult population suffer from chronic kidney disease. That's quite a lot of people. And sometimes our colleagues, especially surgical colleagues, consider somebody to be having chronic kidney disease only as somebody that is on dialysis. Well, this is just the tip of the iceberg again. The dialysis patients is just a fraction, but we see much, much more patients, 15% of the population, that do have chronic kidney disease, and they will progress towards dialysis, but most of them will die due to cardiovascular disease before they reach even the level of being dialysis dependent. And it's a big challenge to take care of those patients. We have an age distribution of chronic kidney disease. Of course, at your age, 20 to 30, almost nobody has chronic kidney disease. But once the age progresses towards 60, 70, and 80, then the percentage of people suffering from chronic kidney disease increases. And I always tell my students, if you are retiring from work, and in Germany we do that now at age 67, then your chance of being healthy is as high as the chance of having kidney disease. And if you have a person in front of you that is 80 years or older, you can bet your salary that this patient has renal disease. Well, with renal disease comes an increase in uric acid level, and that is something you can see on this graph here. For this study, we included more than 5,000 patients with chronic kidney disease. And what you can see in the red line is here that you are indeed able, let's try this here one more time. You can see here that with the decrease in renal function, your chance of suffering from gout increases. So before you start dialysis, every other person had gout. And if you look at hyperuricemia, the percentage of people having hyperuricemia is even higher. Almost 75% of people develop hyperuricemia when their renal function goes down. Why do I tell you that? Well, to alert you that the underlying cause of gout and hyperuricemia could be renal disease with a decrease of glomerular filtration rate. So every patient you see that has gout or hyperuricemia, there you should check for chronic kidney disease. And one last line I would like to point out here is the blue one, this one here. And this depicts the number of patients that are actually treated with gout. And this is embarrassing. This is Germany. and we fail to treat 1/3 of patients with overt gout. They have gout, they know it, their doctors know it, but we still do not treat those patients. And this is something we have to change. Why should we change that? Well, because we know that if your uric acid level increases, your risk of dialysis increases as well. So this is here the risk of dialysis, and here you can appreciate the uric acid level. And as the uric acid level goes down, goes up that way, so goes your risk of ending up on dialysis. So it seems that hyperuricemia and gout are two driving forces to speed up the development of chronic kidney disease. So what could we do? Well, the European guidelines on gout are very specific, and they recommend to use two xanthine oxidase inhibitors as first-line treatment. So we are not talking about uricose urix. This is not first-line therapy. First-line therapy is xanthine oxidase inhibitors. And of course, these xanthine oxidase inhibitors have a different mechanism, as you can see here. We have the febuxostat, which is a selective inhibitor, so that is a plus. It's non-purine based. It has a dual action, as it inhibits both the oxidized and the reduced forms of xanthine oxidase. And this is very important for the nephrologist here. It has both a hepatic and a renal clearance. And this is important because the old school treatment of gout with allopurinol is a very nice one, but you can run into trouble if you treat somebody with kidney disease with allopurinol, because the main metabolite of allopurinol, oxypurinol, accumulates if you treat with that drug, and that accumulation can really cause trouble. If you compare the efficacy of the two drugs of allopurinol and febuxostat, you can appreciate in this slide here that most of the studies show that with febuxostat you can titrate patients much faster and more efficient into the target range. We haven't talked about the target range yet, but it's an important number. It's 360 micromoles per liter. This is the uric acid level you aim for in patients with gout. So it's not enough to normalize the uric acid level, but as in LDL cholesterol and other things we treat, it's important to reach a target goal. Well, if you want to compare the efficacy of the two drugs, I always like to use an automotive example. So the allopurinol is like of the workhorse. It's like a good old Lada. It has a great heating system, and you can put half a horse in the trunk, so that's no problem. If you want to drive from one city to the other very fast, if you want to reach your goal very fast, you might choose another car that has not the horse in the trunk, but the horse in front of the car, as you can see here. So I think if you are working under normal conditions, many patients can be treated with allopurinol, but if you are not able to treat the patients into the target range, and if you have patients with renal disease, then febuxostat is definitely something that offers you much more safety and much more fun to get to the goal. So what about the cross-link between high uric acid level and cardiovascular disease? I have shown you that high uric acid levels are associated with cardiovascular mortality. The question is there a causal relationship? Can we be sure that the uric acid level is responsible for causing the cardiovascular disease? And this study was one of the first that gave us insight into this question. So Dr. Feig here from the US studied adolescents with hypertension, and he asked the question, when really hyperuricemia is causing hypertension, then lowering uric acid levels should lead to a decrease in blood pressure, right? So he did this study in these young people and administered either a xanthine oxidase inhibitor or placebo. And what you can appreciate here is that indeed the treatment with the xanthine oxidase inhibitor was able to lower the blood pressure. Those patients did not receive a blood pressure pill. They just received a xanthine oxidase inhibitor, and that still lowered the uric acid, not only the uric acid level, but lowered the blood pressure. By now, we know that this holds true not only for young adolescents with hypertension, but we have studies for pretty much every age group that showed that if you reduce uric acid level, you also decrease the blood pressure. Well, then there's the big question, is there a difference between allopurinol and febuxostat in terms of cardiovascular events? And this is a big study with big problems, because they ask an interesting question whether maybe febuxostat has a benefit over allopurinol in terms of cardiovascular endpoints. The problem in the study was that, for instance, they lost 50% of patients to follow-up. So they started with a lot of patients, but at the end of the study, half of the patients were gone, and so, of course, were the results. So if we look at the endpoint, there was no difference in terms of cardiovascular death, myocardial infarction, stroke, or urgent revascularization due to unstable angina. And what about all-cause mortality? Well, all-cause mortality, we have again data from the US, from 100,000 patients in the Veterans Affairs population, and there you see no difference between. So this is the LEAF heart failure study I talked to you about. So, and this is the FREED study. The FREED study, as you can see here, is a study over a period of 3 years that looks at the effect of febuxostat in an up-titrating dose on cardiovascular and renal events. And this year at the European Society of Cardiology meeting in Munich, the results of this study had been reported. Appreciate is that even a small dose of febuxostat, 40 milligrams per day, was able to lower the uric acid level well below the 360 micromole per liter level. So 6 milligrams per deciliter is equivalent to 360 micromoles, and what you can see here is that in the study they reached a big difference between the treatment and the non-treatment group. Then they had a composite cardiovascular and renal endpoint, and as you can appreciate here from the red line, the group with the red line was the non-febuxostat group, and they had a higher rate of endpoints. So the authors concluded that febuxostat was able to decrease the number of cardiovascular and renal endpoints, and we will come back to that later if the slides will work. So you have seen this slide already, I know, but repetition is always good. So this slide told you that first 1/3 of patients with renal disease and gout in Germany are not treated for whatever reason, very embarrassing. And this slide also shows you that there is an increase in the rate of hyperuricemia if your renal function goes down. And the question is, even though there is no drug currently on the market that has treatment of hyperuricemia without gout in the label, I would like to give you a sneak preview whether this might be something to consider to give patients without gout uric acid lowering drug. As I said, currently no drug has the EMA or the FDA clearance to do that. Why would that make sense? Well, now we go to Hollywood. And not only you have stars here in your country, Hollywood has stars as well. And I will not show you the whole beauty of those stars here. But as you can see here from the Ratatouille movie, after the fame the Reds had, after the movie came out, then despair came upon those Reds. They were depressed and they didn't know what to do. And in this period of time, a brilliant scientist invited the Reds to die for science. And this is a noble cause for a rat to die. So the rat said, okay, let's do that. We are famous already and maybe we can do something for science. And they came to a lab of Dr. Kang, and Dr. Kang said, okay, this is what we will do. We will mimic chronic kidney disease. And we do that by taking out one kidney completely and taking out 2/3 of the other kidney as well. So it's an established model, the 5/6 nephrectomy model. So they all went under anesthesia. They all got a red urologist taking the kidneys out. And then, everything, once the wounds were healed, she said, okay, this is now the second part of the experiment, because I want to know whether uric acid is making your chronic kidney disease, your severe chronic kidney disease, even worse. So on this slide you can see at time point 0 they came out of the operation theater, and this slide is just looking at proteinuria. And the upper curve shows you the rats that were not happy at all, that they signed the consent to take part in the study. Because on top of 5/6 nephrectomy, they got compounds that increase the uric acid level. And what you can see here is that the proteinuria, so the sign of glomerular damage in the kidney, increased dramatically. But there was another group, and the other group of rats were a little bit happier. Why was that? Because they also got compounds that made the uric acid level go up, but they also got a xanthine oxidase inhibitor. And Dr. Kang concluded from the study, well, a xanthine oxidase inhibitor will not make your remnant kidney grow to a healthy kidney again. But, at least in the rat, the xanthine oxidase inhibitor is able to delay the progression of renal disease. And this seems to be true if you look at several studies that have been performed in humans. They were able to delay the onset of dialysis. And this is important because we are not talking about some numbers here. We are talking about celebrating an anniversary, a birthday, without or with dialysis. So that's a big difference. So the question is, how fast could we see results? And there's one study published in a US journal, and they just treated renal patients for 6 months with febuxostat. And even over this very short period of 6 months, you could see that in the febuxostat group, the glomerular filtration rate went up a little bit, and in the placebo group, the glomerular filtration rate went down. So obviously, within a short period of 6 months, you're able to modify your renal function and slow down the progression of renal disease. The important part is you have to lower the uric acid level to a certain number, and the number here is based on studies is again a level below 360 micromoles per liter. If you do that, you're the lucky one in the blue curve. Then you increase your glomerular filtration rate a little bit. If you just give some pill but your uric acid level still stays above 360 micromoles per liter, then you don't have a protective effect on the kidney. So what about a big study? And the big study was just published out of Japan. 400 patients that never had gout in their life were enrolled into that study. So they were all chronic kidney disease patients, and they were treated with either placebo or febuxostat. And what you can appreciate again is that the treatment with febuxostat lowers the uric acid level quite dramatically, well below your ideal 360 micromoles per liter. So this part did work splendidly. But if you look at all the 400 patients over a period of 2 years, there's a lot of scatter. So the data are not really making a clear point what we should do. Well, for that reason, we have to break down the groups, and this is had been done in this slide here. So they divided the patients in proteinuric and non-proteinuric patients, and what they could see is that if you don't have proteinuria but chronic kidney disease, then giving febuxostat will slow down the decrease of renal function decline. If you have proteinuria, then it's probably too late to have a modifying effect on renal function. They also looked for a second point here: when should we start to lower uric acid level? So they divided the 400 patients into 2 groups, in the patients with rather better renal function or worse renal function. And what they could see here is that in the left side of the panel, that the patients with a better renal function benefited significantly from lowering of uric